Please tell me if we are live. Good evening, everyone. Good evening, everyone. Please tell me if we are live. Good evening, everyone. Please tell me if you are able to hear me. Good evening, everyone. Please tell me if you are able to hear. So I think we should start. Uh, yeah. So let's start with the definition of infertility. So what is infertility definition? The definition is if a couple is living together for 1 year and having unprotected intercourse, that is also known as sexual cohabitation. Okay, if a couple is living for 1 year and is uh, having unprotected intercourse till that couple is not able to conceive, then it is known as infertility. Okay, so it can be male infertility and female infertility both. Okay, so the test to diagnose male infertilities has been semen analysis. So the semen analysis is the main test which we do for the evaluation, or you can say initial evaluation of the infertile couple. Okay, so this is a main test or the initial evaluation. Why it is a main test? Because male can be responsible and female can be responsible, and moreover this test is very cost effective and non invasive. So koi bhi couple, if it comes to you with infertility, then at first you are going to do is you are going to do the semen analysis of the male. Okay, so what are the criteria to learn this? All this criteria, it is you have to learn two terms, 15 and 4. Okay, so all the parameters will be in 15 and 4, 1, 5 and 4. So WHO has given some minimal criteria. Okay, the semen volume is what is the semen volume minimal criteria? Ideally it should be more than 1.5 ml. It should be minimum 1.5 ml. Okay, semen volume. Again, it is somewhat near the 15. Okay, then semen sperm concentration, that is the concentration of the sperm, count of the sperms per ml. This is the term which we most commonly use. Okay, this is the term which we most commonly use. So if they haven't written sperm count or sperm concentration, it is understood that it is sperm concentration. Sperm concentration should be more than 15 million per ml. Okay, sperm count is total number of sperms in the ejaculate, per ejaculate. So obviously it will be more, and it is 40 million per ejaculate. Okay, so usually if they have not written the sperm concentration and count, so it means that it is the sperm, it means that it is the sperm concentration. Okay, again I'm telling you, because these are something we do it clinically. Okay, now motility is whether the sperm is able to swim and go into the fallopian tube or not. That is what is motility. So out of all the sperms, 40% should be motile. Okay, and what is progressive motility? Progressive motility means that it is something that the sperms they are moving, but they are not able to progress in the right direction. So if they are not able to progress in the right direction, then that motility is of not use. So ideally the motility of the sperm should be 40%, but progressive, that is they are reaching the fallopian tube, it should be 32%. Okay, and non-progressive is of course 8%. So this 40 you have to split into 32 and 8. And morphology means that this sperm is looking normal, it is not handicapped, it is having the tail, it is having the proper acrosome, and it is having the proper nuclear structure is normal. Matlab, by look wise the sperm is normal. So that criteria is only and only 4%. So you can see that all these criteria, they are between the 15 and 4. Okay, and in the motility, to split that motility, you have to divide it into 32 and 8. I hope you understood. Now, let us discuss what is IUI and what is IVF and what is ICSI. Okay, what is IUI? We take the semen of the male partner, we wash this semen, and then we insert that semen into the uterus of the female. Okay, so this basically is intrauterine insemination. What is IUI stands for? The IUI stands for intrauterine insemination. Okay, what do we do in intrauterine insemination? We take the male semen and we wash that semen, and we put that washed semen into the uterus of the female. Okay, basically when we are doing the IUI, we are doing IUI basically in the mild oligospermia. Remember this word mild. It is not that it is severe or moderate oligospermia, only we can do it in mild oligospermia. Okay. Now what is IVF? IVF means that we are doing the fertilization in the in the vitro, not in the uterus. The fertilization is occurring in the vitro, IVF, in vitro fertilization. Okay, so it means that the fertilization is occurring in the vitro. Vitro means at an artificial space, not at the natural space. Okay, so now what as you all know that IVF is also known as test tube baby. So where is the fertilization occurring? Fertilization is occurring in the test tube. So what we do basically in IVF is we induce, do the ovulation induction in female, and we make 15 ovum. मतलब एक ही cycle में, in one cycle we make 15 ovum students. Okay, and we then take out that ovum and put that each ovum in a separate test tube. Okay, as you can see that I have put in the separate test tube, and then in that every test tube we put the washed semen. Okay, now in this test tube the fertilization is occurring, and then we will get that embryo, the blastocyst, when it is formed here. Then we will transplant that. See, here it is written ET. What is ET? ET means embryo transfer. When now the blastocyst is formed, that is implanted into the uterus of the female. Okay, we are taking the semen, we are taking the ovum, taking out the semen of the male, taking out the ovum of the female, taking the semen of the female, putting them in the test tube, and then doing in vitro fertilization, and then the embryos are transferred. Why we do the in vitro fertilization? Why we are doing 15? To increase the success rate. Oh, at least one baby should, the female should get one fetus implanted correctly. Okay. Okay. Now, what is ICSI? ICSI is ICSI. Full form is intracytoplasmic. In whose cytoplasm? In the ovum cytoplasm. Intracytoplasmic sperm injection. Okay. So what is basically intracytoplasm? In the sperm, we are putting the in the cytoplasm, we are putting the sperm. Okay, in the cytoplasm, we are putting the sperm. Do you got it? Okay, so now even one sperm is sufficient for this procedure. As you can see that here I have shown you in the diagram, this blue color is the ovum, and with the help of the injection, and I am putting the sperm. Okay, in this injection, in its syringe, it is the one sperm is there. Okay, so even one sperm is sufficient. So when we do this IVF, and when we do this ICSI, IVF is done because here we are doing in vitro fertilization when tubes are blocked. Okay, when tubes are blocked, then we are doing the IVF. Okay, and when we are doing ICSI, of course in ICSI also the fertilization is taking place outside. So we can do ICSI in tubal blockage and severe oligospermia, or you can say severe problem in the semen. Even if one sperm is there, we can get the fertilization done in the case of ICSI. Okay, so if you have understood all this, now you will understand that which criteria is more important: morphology, motility, or count. Okay, which criteria is more important? So see, in ICSI we saw that even one sperm was able to fertilize the ovum. It means that sperm has not to swim. Motility is not essential. That sperm has not to be many. It means count is not essential, but that single sperm should have the proper acrosome, proper nucleus, and proper tail. Then only that sperm will be able to fertilize that ovum. So the morphology is the most important criteria. Please make it clear in your mind. Morphology is the most important criteria. Here I would like to discuss with you Klinefelter syndrome. Okay, what is Klinefelter syndrome? It means that the genotype of the male is double XY. It is sex chromosome trisomy. Okay, there is one extra X in the male. Due to that extra X, the male is giant in size. 2 G's you have to remember: gynecomastia and the giant female. There is significant gynecomastia. This is very, very important. Okay, as lot of questions are coming on agiospermia, and on Klinefelter syndrome lot of questions are coming. But in the Klinefelter syndrome there are two G's, gynecomastia, and the male has long height, giant male, much more height than its siblings. Okay, now what is other fertility factor? That male Klinefelter male is having agiospermia. Okay, and that male is giant, but that male also has central obesity. Central obesity. So that are the four criterias which you have to learn for the Klinefelter syndrome. Okay, good evening, Aftab. Okay, so now let's see some particular characteristics of spermatogenesis. The spermatogenesis takes 75 days. Okay, it is a cycle of 75 days. Question are coming on this. Okay, next is the sperms. They are their spermatogenesis start in the Sertoli cells, and the sperms, they mature, they divide, and they grow in the tubules and in the epididymis respectively. Okay, they in the epididymis they gain motility. Again I am telling you, this is asked many times, that the sperms attain motility in the epididymis. Okay, the sperms, they mature or they divide, undergo meiotic division, form the Sertoli cells, then they come into the lumen of the seminiferous tubules, and then they attain motility in the epididymis, especially in the caudal end. Okay, now let us study agiospermia. Lot of questions are coming on agiospermia. If they tell you that agiospermic male is having giantism, gynecomastia, and central obesity, then it is Klinefelter syndrome. Okay, now how to diagnose agiospermia? Agiospermia means there is semen but there is no sperm, zero sperm. So it can be of three types: pre-testicular, testicular, and post-testicular. Okay, the pre-testicular means that the defect is above the testes. That the defect is above the testes. As in female we have HPO axis. Similarly in the males we have hypothalamus, pituitary, testicular axis. Okay, above that testicle, what are there? It is hypothalamus and pituitary. If the defect is in the hypothalamus and pituitary, then no gonadotropin releasing hormone will be there, no gonadotropins will be there. Such type of pre-testicular agiospermia, there is decrease in the FSH and decrease in the testosterone both. As there is no FSH, no gonadotropin releasing hormone, so testes will not be so the testosterone will not be formed. It is but obvious. So it is known as hypogonadotropic hypogonadism. Okay, hypogonadotropic. Okay, gonadotropic means FSH and LH. They are in hypo because the defect is above the testes. Okay, let us discuss testicular. In the testicular, the fault is at the testes. Okay, let me tell you one more thing about the hypogonadotropic. The example of it is Kalman, and in the Kalman there is a typical characteristic of anosmia. Do you understand? Anosmia. Smell nahi aati hai Kalman syndrome वाले को. ठीक है? If a patient is coming to you with agiospermia, you are going to get the FSH LH done. If FSH is less, you will suspect Kalman and you will ask the patient that do you have smell or not. If the patient says no, I don't smell, so then your diagnosis is Kalman. You have to learn only one etiology of hypogonadotropism. Let us discuss the testicular. It means the fault is at the testes. FSH was being produced, gonadotropin releasing hormone was produced, but the testes were at fault, so they were not able to produce the testosterone. Okay, as I told you that you will get the FSH done. So here, due to the negative feedback, because testosterone is not produced, so no one will be able to do the negative feedback. So negative feedback is loss, because testosterone gives the negative feedback to the hypothalamus to decrease the FSH. Because as testosterone is decreased in the testicular azoospermia, so no one is going to give the negative feedback. So here the FSH will be increased. These type of azoospermia is known as hypergonadotropic. Pre-testicular is known as hypogonadotropic and testicular is known as hypergonadotropic. The diagnostic test for the testicular azoospermia is FNAC. ठीक है, FSH LH help us to guide, but the diagnostic test is testicular FNAC. Okay, next is the what is the treatment in the pre-testicular? As you have seen that there is fault at the pituitary and hypothalamus level, so we will give the gonadotropin releasing hormone pulsatile. Okay, yesterday I explained that continuous GnRH leads to antagonist GnRH effect. So here especially we have to give pulsatile GnRH in the case of pre-testicular, or we will give human menopausal gonadotropic. In the menopausal female urine, FSH LH, they are in the high amount, so lot of FSH LH is there. So that is why it is known as human menopausal gonadotropin. Menopausal gonadotropin means in the urine the FSH LH are there. Okay, so for the treatment of pre-testicular azoospermia, we can give GnRH, or we can give the human menopausal gonadotropin, because human menopausal gonadotropin means FSH and LH. Okay, in the case of the hypergonadotropic hypogonadism or testicular failure, the treatment is testicular sperm aspiration. It is possible that in the semen we are getting we are getting azoospermia, but some sperms are present. So that is why we do FNAC as a diagnostic test and testicular sperm aspiration. What are the examples of testicular azoospermia? Cryptorchidism, mutation in the Y gene, radiotherapy, chemotherapy. These all are the example. Now let us take the post-testicular. Okay, they have asked many times in your exam post-testicular. In the NEET PG and INS set, they have asked pre-testicular and testicular. So it is hope that they will ask you this time pre-testicular and testicular. Please learn this azoospermia. This is very important part of infertility. In the post-testicular, there is obstruction after the testes, in the epididymis, in the vas deferens, in the tubules. Okay, so now the gonadotropins, they are normal because FSH LH is getting released, and they are also being the negative feedback is also being done by the testosterone. Okay, the negative feedback is also done by the testosterone. So gonadotropins are normal. Once again, in the pre-testicular, it was hypogonadotropic. In the testicular, it was hypergonadotropic. In the post-testicular, it is normogonadotropic. This has the best prognosis. That here, what is there? Sperms are being produced and there is obstruction. So you have to just take out the sperms. This has got the best prognosis, and this was asked in your exam. So in the cystic fibrosis, you should know that there is congenital absence of vas deferens. Okay, there is congenital absence of vas deferens bilateral. So they ask you what type of azoospermia is there in the cystic fibrosis. The azoospermia in the cystic fibrosis is obstructive because there is congenital absence of vas deferens. Okay, now what are the techniques by which we can aspirate the sperm? MESA, PESA, TESA and TESE. Okay, what is MESA? MESA means microsurgical. What does M means? M means the technique, microsurgical. And where E has come, MESA, PESA, इसमें सब में E आया है. ठीक है, तो E means epididymis. Obstruction can be after the epididymis. राइट, सो मेसा और पैसा में ई का मतलब एपिडाइडमस है, एस ए का मतलब स्पर्म एस्पिरेशन है. ठीक है, सो मेसा मीन्स माइक्रोसर्जिकल एपिडाइडमल स्पर्म एस्पिरेशन. पैसा मीन्स परक्यूटेनियस एपिडाइडमल स्पर्म एस्पिरेशन. टेसा मीन्स टेस्टिकुलर स्पर्म एस्पिरेशन एंड टेसे मीन्स टेस्टिकुलर स्पर्म एक्सट्रैक्शन, खींच के ले आना. ठीक है, खींच के ले आना. एस्पिरेशन इज समथिंग मीन कि निडल से एस्पिरेट कर लेना. ठीक है, एक्सट्रैक्शन मीन्स खींच के ले आना, कहीं कोने में भी पड़ा. इनमें से सबसे बेस्ट टेसे है. ठीक है, टेस्टिकुलर वाले जो प्रोसीजर हैं, टेसे, टेस्टिकुलर और टेस्टिकुलर स्पर्म एस्पिरेशन और टेस्टिकुलर स्पर्म एक्सट्रैक्शन, ये हम जो है टेस्टिकुलर एजोस्पर्मिया में भी कर सकते हैं. Okay, now let us discuss. That's all about the male infertility. Only azoospermia is important and the WHO criteria was important. For that I have given you the mnemonic 15 and 4. Now female infertility. The problem in the female can be at the level of ovaries. The problem in the female can be at the level of tubes, and the problem in the female can be at the level of uterus or endometrium. When it is at the level of the ovary, it is known as ovarian factor. Let's discuss the ovarian factor first. Okay, ovarian factor में दो चीजें आती हैं. Number 1 है ovarian reserve and the second is ovulation. What is ovarian reserve? You all know that the follicle synthesis start in the intrauterine life, isn't it? At 20 weeks it is 7 million. At the birth it is 2 million, right? So it is completed. The maximum follicle formation is at 20 weeks. Now we have to see in an infertile couple that infertile couple is having the follicles or not. It is quite common that the couple does not has that follicles. So that is calculated by ovarian reserve, and this is very, very, very important. Okay, first important thing in infertility was WHO criteria. Second important thing was azoospermia. Third important thing is ovarian reserve, and it is measured by AMH. What is AMH? AMH की full form है anti-Mullerian hormone. As we do in the quiz today, this is the hormone which is produced by the granulosa cells. Granulosa cells जो हैं वो follicle के cells होते हैं. Follicles have two type of cells, granulosa cells and the theca cells. Okay, granulosa cells, they synthesize estrogen, they synthesize the AMH, and they synthesize the inhibin. So it means if follicle is there, granulosa cell is there, then it will synthesize AMH. What is basically the function of AMH? Basically, it does not let the Mullerian ducts to grow. Mullerian derivatives जो होते हैं, Mullerian duct से जो derive हुआ है, it does not let the Mullerian duct derivative to grow. Okay, in other words we can say it decreases the sensitivity of antral follicle to FSH. It decreases the sensitivity of pre-antral follicle to the FSH. Yeah, you are right, Isaac. Dr. Isaac, you are right. Okay, so anti-Mullerian hormone is this. Okay, now what questions are asked on this? What is its function? Its function is number 1, it decreases the sensitivity of antral follicle to FSH. That is, this hormone decreases the sensitivity of the antral follicle. Okay. Number two, it does not let the Mullerian duct to grow. Mullerian duct derivative to grow. Second thing which they ask about the ovarian reserve is that what is its biochemical composition? It is a glycoprotein. Okay. They ask the chemical composition of two hormones. One is HCG and another is AMH. They both are glycoprotein, and they confuse you by telling that they are lipoprotein. No, they are not lipoprotein, they are glycoproteins. Okay. And they are secreted by which cells? Their next question, they are secreted by granulosa cells. If the AMH is good, it means that the egg is good. Okay. If the AMH is good, it means the egg is good, and it means the IVF is successful. So it tells the prognosis of IVF. Okay. And the another important thing which they can ask you is that why it is the best parameter to diagnose ovarian failure. It is the best parameter because it can be done at any day of the cycle. It is not that patient has come to you and you will ask the patient to come on day 3, because the rest all the hormones are done on day 3. It can be done any day. Okay. The things which you have to learn about anti-Mullerian is its function. It is glycoprotein. It is secreted by granulosa cells, and it can be done at any day. What is the normal value of anti-Mullerian hormone? It has been asked, because anti-Mullerian hormone is such an important test. The normal value is 1 to 4 nanogram. The values are in nanogram. 1 to 4 nanogram per ml. If it is less than 1, it is abnormal. Please learn this value. Then don't say कि ma'am ये आपने नहीं कराया था, या ma'am what all this is coming difficult. It is not difficult. It is very important. 1 to 4 nanogram per ml is the normal value of the AMH. Okay. It can be done on any day. The other tests which we are going to do for the to know what is ovarian reserve, how is the ovarian reserve, is the day 3 FSH and day 3 antral follicle count. What is day 3 FSH? Ma'am, I want to learn odds for FMG. Beta, this is 101% for FMG. This is not for Dr. Sean. It is not for other exams. This is 101% for FMG. It has been, AMH has been asked. Okay. 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 Much concise version will come 1 week before the exam, but at this stage we have to learn all this. Okay. Questions are coming on all this in your exam. They have come previously. Okay. Now let us see what is day 3. What are the tests which we do on the day 3? The test which we do on the day 3 is the FSH and antral follicle count. If the follicles are failing, ovarian failure hota hai, so you know that FSH increase. It is the earliest parameter. Didn't we learn in menopause yesterday? So day 3 FSH. If FSH is increased, then it means that the it is a ovarian failure case. Okay. Antral follicle count. Dr. Sean, the classes started from yesterday. It is already on my channel. You can see there. Okay. Yesterday class is already on the channel. It has been started yesterday. Okay. So day 3 antral follicle count is the count. You all know that under the influence of FSH, the follicle grows. Okay. So if the follicle is growing, it means that the ovarian reserve is there. And on day 3, a antrum, a cavity. You get the question on this thing, na? In exam, in FNG, you get the question on this thing that there is an antrum and they told you to diagnose. See, that is how they ask. Okay? Why they only ask you antral follicle? Why don't they ask you any other follicle? Because this is what it is counted in the infertility patients. Okay, on the day 3 the antral follicles are formed and we count it, okay, by ultrasound, that how many antral follicles are there. If they are 7, it means it is normal. If they are less, it means that ovarian reserve is poor. Okay. Okay, now you can antrum is something cavity. Antrum means cavity. So yesterday we did the antral follicle in detail. Okay, so these are the 3 tests, but out of these AMH is the best. This has question has come in FNG in 2018. Okay, so let's start the ovulation test. See, ovulation, if the ovulation occurs, then corpus luteum is formed. Corpus luteum synthesize progesterone. If progesterone is there in the body, then it means ovulation has occurred. If ovulation has not occurred, it means that there is no corpus luteum. Okay? If the progesterone is there, it means corpus luteum is there. If corpus luteum is there, it means that ovulation has occurred. So what are ovulation tests? Ovulation tests are nothing but they are progesterone tests in the luteal phase. But in the luteal phase, not in the follicular phase. Okay, that you all know. Now, what is the best test? Yeah, beta, we will be doing full lobs. Don't worry. Dr. Sean, we will be doing full lobs. You are on day 2nd. We will be completing the full lobs. Don't worry. Okay. So, in the, what are the ovulation tests? So, ovulation test means progesterone test in the luteal phase. Best test is the endometrial biopsy. And it is done in the premenstrual. Menses आने से थोड़े दिन पहले. ओके, मेंसेस आने से थोड़े दिन पहले. ओके, it is the endometrial biopsy. Please don't say serum progesterone. ठीक है, अब you all know what is the function of progesterone. It is makes the endometrium secretory. It makes the endometrium secretory. Up, if there is progesterone, then only the endometrium will be secretory, right? And then only the endometrium on the histopath in the biopsy will show you the secretory changes, right? Isn't it? So you should know this, that the endometrial biopsy is 101% confirmation that progesterone came and acted on the endometrium. Why don't you mark it in the quiz that it is the best test? It is the best test. And why we do it in the premenstrual period? Because in the luteal phase, what does premenstrual period means? Menses आने से थोड़ा सा पहले, मेंसेस आने से थोड़ा सा पहले, ठीक है. मेंसेस आने से पहले मतलब ल्यूटियल फेज. तो उसमें हम देख लेते हैं कि सेक्रेटरी चेंजेस आर देयर और नॉट. ओके, so once again, type in the chat box. All of you who are watching, please type in the chat box which is the best test for ovulation. Okay, Dr. Sean, Isaac, and Aftab, you are going to type in the chat box which is the best test, so that it becomes 100% imprinted in your mind. And which in which period it is done. It is done in the late luteal phase, or it is done in the premenstrual, or it is done in the post-ovulatory. All are one and the same thing. Okay, all are one and the same thing. Okay, serum progesterone is checked at day 21, because at day 21 it is the serum progesterone is maximum. It because at day 21 the serum progesterone is maximum. In this question can come in another term also. When is the serum progesterone maximum? It is maximum at day 21. Okay. Now you all know that progesterone is a थर्मोजेनिक हार्मोन, प्रोजेस्टेरॉन बॉडी का टेम्परेचर इंक्रीज करता है. प्रोजेस्टेरॉन इंक्रीज द बॉडी टेम्परेचर. सो if there is increased basal body temperature post ovulation, it means that it is the ovulation has occurred. If the cervical mucus is thick, progesterone makes the cervical mucus thick. और ईस्ट्रोजन जो है वो स्ट्रेचेबल बनाता है, स्पिन बार्केट इफेक्ट बनाता है. ठीक है. ईस्ट्रोजन, व्हाट इज द फंक्शन ऑफ ईस्ट्रोजन? ईस्ट्रोजन जो है रिटेन द सोडियम क्लोराइड एंड वाटर. सॉल्ट एंड वाटर रिटेंशन इज देयर इन द cervical mucus. Once the water enters in the cervical mucus, then the mucus will be spin bucket, stretchable, right? You all have touched any jelly. If that jelly contains more water, it will stretch, right? And that due to the presence of NaCl, there is the fern pattern on drying. Okay. What does progesterone do? Progesterone increase the mucin content. More mucin is there, more protein is there. That is why there is mucus gets thick. Okay. Okay. Now another way is how you can diagnose. If cervical mucus is thick, it means that it is the ovulation has occurred. Okay. The ultrasound test. On ultrasound, we see the ovum size. If the ovum size has reached 1.8 to 2.2 centimeter, or you can say 2 centimeter or 2 mm. Okay. Yes, Isaac, you are right. Dr. Isaac, you are right. No fern pattern is seen in the luteal phase. Okay. 1.8 to 2.2 centimeter. Please note it is centimeter. In the mm, it will be 18 to 22 mm. Okay. This is the size of the mature follicle. After this size, the corpus luteum is formed in the ovary. In the ultrasound, we follow the size. If there is a ruptured follicle in the ovary, in the luteal phase, then it means that it is the corpus luteum. Okay. That is why the size is asked to you. It is 18 to 22 mm or 1.8 to 2.2 centimeter. Okay. Now, what is the main cause of non-ovulation? The main cause is PCOS in females. PCOS, as you all know, leads to non-ovulation, right? Decreased oligo-ovulation या no ovulation. ठीक है. The treatment of ovulation is या decreased ovulation is letrozole or clomiphene. ठीक है. Letrozole, students, is drug of choice. As you know that most common cause is PCOS. In the PCOS, ovulation does not occur. In the PCOS, the drug of choice is letrozole. They are only going to ask what is the drug of choice in PCOS for ovulation. The answer is letrozole. Before 5 years, the drug was clomiphene. What happened that letrozole has totally replaced clomiphene? Please listen here carefully. That is why the questions came. Okay. The clomiphene is a serum. Serum means selective estrogen receptor modulator. Selective estrogen receptor modulator means it is estrogenic at some site and it is anti-estrogenic at the other site. Okay. Now this clomiphene is anti-estrogenic at endometrium. That is why it leads to endometrial thinning. ठीक है. अब क्लोमिफिन जो है हाइपोथैलेमस में ईस्ट्रोजन रिसेप्टर्स को ब्लॉक करके एफएसएच तो रिलीज करा देती है. ओके. नो Isaac, please, it is not, it's the wrong answer. Please listen carefully here. Okay. You all of you know that clomiphene blocks the estrogen receptor in the hypothalamus and releases FSH. and that FSH leads to ovulation, isn't it? You all know. Now, but this clomiphene is anti-estrogenic on the endometrium. It leads to endometrial thinning. In spite of the good ovum, the implantation does not occur. Implantation does not occur due to endometrial thinning. Now you tell me, if there is endometrial thinning, then what will be the effect on menorrhagia of the patient? What will be the effect on the menorrhagia? Menorrhagia will decrease. Okay, in one or the other word they are asking this effect. The only you have to learn that this clomiphene is SERM and it is anti-estrogenic on endometrium. That is why, in spite of the good ovum, the implantation does not occur, so fetus is not produced at such a high rate. Okay, and number one. Number two is that at the, yes, Isaac, you're right, that menorrhagia decreases. Okay, menorrhagia decreases. So they ask you, patient is taking clomiphene, what is the effect on menorrhagia? It decreases. It does not lead to menorrhagia. Though it has a significant effect of endometrial thinning, there is no such effect on the endometrial thinning with letrozole. That is why the letrozole has become a drug of choice. Okay. Now, other factors which you have to learn, the all are the good factors. Number one, the clomiphene is less teratogenic. Okay? Letrozole is teratogenic, but its half-life is less. Okay? Till the fetus is formed, letrozole body से निकल जाती है. ठीक है, बॉडी से निकल जाती है, इसलिए उसकी टेराटोजेनिक का कोई असर नहीं पड़ता. ठीक है, दैट इज वाई इट्स टेराटोजेनिक इफेक्ट डज नॉट इफेक्ट द फीटस, बिकॉज टिल द फीटस इज फॉर्म द लेट्रोजोल has very less action time, 48 hours. That is why it came out of the body. Okay, so but as such the clomiphene is less teratogenic. More fetuses, more good ovulation occurs with clomiphene. So the couple is benefited, right? You all know in IVF we do many embryo transplantation. So multiple pregnancies is a good factor. Okay, you got it, Isaac, that multiple pregnancy is a good factor. Okay, and it can be used with gonadotropins. Even it can be used with gonadotropins. Okay, so only one bad effect of clomiphene which has made it a second drug of choice is it does endometrial thinning. Rest all the clomiphene has all the good things. It is less teratogenic. It is not teratogenic. Rather, I should say it is not teratogenic. Okay, it leads to increased multiple pregnancy because it leads to good ovums. Okay, many ovums and good ovums, and it can be used with gonadotropins, whereas letrozole has not such effect on endometrium, and we get more pregnancies with the letrozole. Okay, and less factor. Last but not the least is the tubal factor. Tubal factor means tubes have blocked, so ovum cannot reach the tubes, so fertilization cannot occur. It is found in PID. Last FMG question: which is the most affected organ in the TB? It's the fallopian tubes. Now I ask you, which is the most commonly affected part of the fallopian tube which is affected? It is ampulla. Okay, it is ampulla. Now there are two reasons of tubal blockage. Okay, two main reason. One is PID and the another is genital TB. Which is more common? PID is more common. PID is more common. Okay, which is the most common factor? Ovulatory factor or tubal factor? Ovulatory factor is most common. Okay, right. First test which we do to diagnose the tubal blockage is the HSG. Because HSG is cost effective, because HSG is done in non anesthesia. We have not to give anesthesia to the patient. We have not to call the patient next day. And HSG is not a costly procedure and not so invasive as compared to laparoscopic chemopertubation. Okay, but the best test is chemopertubation. Okay, we will discuss both these tests. The best test is chemopertubation. Okay, now what is the best investigation for infertility, or what is the best investigation for tubal blockage? The best investigation for infertility is laparoscopy, hysteroscopy, chemopertubation. What is laparoscopy? पेरिटोनियम में हमने प्रोब डाला है, लेप्रोस्कोप डाला है, और हम देख रहे हैं, we are seeing the peritoneum, whether the uterus is okay, tubes is okay, tube has been blocked or not, ovary PCOS है कि नहीं, मतलब totally outer morphology in the peritoneum of the genital tract. What is hysteroscopy? Uterus, in the uterus we have put the probe. Okay, so this have been asked in FMG. In the hysteroscopy, can we see the uterus surface? No, we cannot see the uterus surface. In hysteroscopy, we have put the scope in the endometrial cavity. Uterus surface is in the peritoneal cavity. We cannot put the probe. Also asked in the previous year question, which is the dye which we use for chemopertubation? The dye is methylene blue dye. Okay, methylene blue dye. Okay, what do we do in methylene? How we do chemopertubation? In the uterus we put the cannula, and the name of that cannula is Leech Wilkinson. एक तीर की तरह होता है, ठीक है, तीर की तरह होता है, and the upper end there is a cone like structure and lower end is a tube. ठीक है, from that we put that cannula in the cervix. Okay, and from that cannula we put the dye, and then we see whether the dye is coming out of the fallopian tube or not. So where we will see that dye is coming or not? We will see it in the peritoneal cavity, where the fallopian tube opens. Fallopian tube opens in the peritoneal cavity. Okay, so one probe, the cannula is in the uterus, and to see whether the dye is coming out or not, Rubens 2 we can use. I don't understand you, Isaac. I don't understand what is Rubens 2. Please write in detail. Okay, so methylene blue dye we inject in the uterus, and then there is coming out of the dye in the peritoneal cavity from the fallopian tube fimbriae that we see in the peritoneal cavity. Okay, now what the questions which are asked in the hysteroscopy, laparoscopy and chemopertubation are here on your slide. Rubens cannula, I will study it and tell you whether Rubens cannula can be used or not. Okay, so pressure is maintained in laparoscopy in the gynae procedure is 10 to 15 mmHg. The pressure maintained in the gynae surgery in the peritoneum, we have to inflate the peritoneum. Okay, we have to inflate the peritoneum to maintain the pressure so that we can see whether the organs have been inflamed or not, right? So the pressure is 10 to 15 mmHg. Please note down, you all mark there 20 mmHg. It is 10 to 15 mmHg, not only in the gynae, in every procedure. Okay, the pressure is around 12 mmHg. That is why we mark it 10 to 15 mmHg. What are the solution? As I told you here, we take the CO2 gas and we inflate the peritoneal cavity when we put the laparoscope. In the similar way, when we put the hysteroscope, we put the fluid to inflate that uterus cavity. Okay, if we are using the bipolar cautery, then we will inflate the uterus by isotonic or NS solution. Okay, because in the bipolar cautery there is no current in the body. This you have to learn. It is quite a big thing to explain. You have to learn. In the in the bipolar cautery we use NS. Okay, in the unipolar cautery we use glycine or non-ionic. Okay, these things you have to cram. In the bipolar हम बाई आयंस वाला सोल्यूशन लेते हैं, दैट इज NaCl. इन द यूनिपोलर एक ही पोल है जिसमें, उसमें हम ग्लाइसिन लेते हैं, नॉन आयनिक सोल्यूशन. नाउ लेट अस सी दिस इमेजेस. They have come in the past in your exam. This first image is of cornual blockage on HSG. As you can see, the dye has not gone. The site of blockage is cornual blockage on HSG. ठीक है. The another image is of OHSS, ovarian hyperstimulation syndrome. Okay, here there are big you can see ovarian follicle. ठीक है. These all are ovarian follicle. Ovulation induction has been done and hyper ovulation induction is there. ठीक है. Ovarian in hyperstimulation. If they are big follicles, then you have to diagnose it as ovarian hyperstimulation syndrome. You have to differentiate it from PCOS. How you will differentiate it from PCOS? In PCOS there is necklace pattern. All the follicles are in the periphery and there is in between it is the stroma is hyperstimulated, whereas in the ovarian follicle there is no stroma. You can see only and only follicles here, only and only follicle. In the PCOS there is lot of stroma. Okay, now this is the image of fimbrial blockage. Dye has gone up till last, so this is the image of fimbrial blockage. Okay, only two types of blockage will be asked, either the cornual or fimbrial. If the tube is, you are seeing the tube, it means it is fimbrial. If you are not seeing the tube, it means it is cornual. Now what is this has been asked. As you can see, the tube is swollen. These both are hydrosalpinx, because in the question which come is, if there is written fimbrial blockage, site of blockage, you will write it fimbrial blockage. If they ask you the diagnosis, then the diagnosis is hydrosalpinx. Let us see the another image which can come in your exam. This is Verres needle. Okay, the gas is inflated to, we already studied in the laparoscopy, we inflate the gas. Right? So it is inflated by the Verres needle. CO2 गैस डालते हैं लेप्रोस्कोपी में पेरिटोनियल कैविटी को इन्फ्लेट करने के लिए, Verres needle. ओके, कैविटी को इन्फ्लेट करने के लिए Verres needle. ओके, एंड दिस इज the image of HSG, image of Asherman syndrome. This is your last year paper. In the Asherman syndrome, the anterior and posterior surface of the uterus is adhered. That is why uterus cavity कैसी होती है? You will tell me how is the uterus cavity. Uterus cavity is like this. Okay, it is like this triangular. पूरा ऐसे व्हाइट रेडियो पेक आता है. अगर बीच में कहीं पे भी गैप आता है तो इट मीन्स इट इज एशरमैन सिंड्रोम. ओके, so this is the if there is gap, it means there are adhesions. Okay, now this is what we see in the laparoscopy. Okay, this is what we see in the laparoscopy. Here we see the we put the dye from the cervix, and here we see the dye in the peritoneal cavity. Okay, so if the dye is coming, it means the tubes are intact. And the last, this is the image of Leach-Wilkinson cannula, which is done to do the hysteroscopy. I think all of this is clear to you. If you have any queries, then you can tell me. Till then, I will take a call. Okay, here I would like to tell you, Dr. Isaac, you have written vigorous curators. Vigorous curators is also the reason, and genital TB is also the reason. I hope everything is clear to you. I here close the session.